Welcome to Health Friday.
Thank you very much.
Uh-huh.
Today you're having nominated senator,
Yes.
elected senator,
Yes.
so future senator.
Future
Well,
senator.
yes. I mean, these are the people whom we elect and we depend on to do our will. Okay? Not their will, ours.
Service to the people.
Yes, so when they're still freshly minted, we want them to come in and tell us these lovely ideas that they have, what they're going to do, how they want to. And we also tell them we'd like to have them back again because we will be holding them to account. We'll be asking, so-and-so, when you were here last, you told us this. In fact, let me just quote you verbatim. You said blah, 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 blah. How far have we gone with that particular matter? Yes.
Like, for example, what Senator Omtata was talking about, the Health Service Commission. For a very long time, no legislator has been willing to
publicly talk about it
and stake their reputation literally on it because of the kind of landmines that will come their way, considering for many it looks like you're disrupting and disturbing the evolution of health and wanting to reverse it back. But I thought the kind of thoughts that he had is actually what we've been discussing in this situation room about standardizing care, so that whether you're in Nyandarua, whether you are in Turkana, you can still be sure to get the same kind of care.
Whether you're in Ilkek, yes, or NHIF, on your way to, it's just before more than that.
So now we know exactly where it is.
Now, remote places, they're in Kenya, people live there, okay? And they need these services.
Yes.
Oh, yeah. So I think it's a good place to start, and I think it's about hitting the road, hitting there.
You hit the road running.
While it's still hot.
While it's still hot.
Yeah.
Yes.
While the iron is still hot.
Hit the road.
Hit the road. You strike.
You strike.
You
Strike while the iron is still hot.
No, that's the rod. Now the road.
Hit the road running.
Yes.
My friend.
Which one do you want?
Kisungu.
Both.
No. I see what Eric is saying. Ukichapa na road, unakimbia. No, Eric, see here.
Hit the road
Strike.
running.
Okay, let's
strike the road.
Yeah,
while
let's
still
work
hot.
with strike.
Strike while the iron is still hot.
Yes, yes. Strike.
Don't strike the road.
Yeah.
Eric was hitting the road running.
Hit the road running and strike the road. Okay.
Yeah.
So that conversation is actually interesting, and that's why we engage in a bit on it. And in fact, even him giving that background. Look, the report of the Committee of Experts on Constitution Review had said it would be nice to have this kind of commission, but they were only hesitant because, of course, they were balancing the politics and saying that whole excuse of there'd be many commissions, that was hogwash.
Yeah.
Because they gave the option of the Human Rights, Gender and Equality Commission to be split. And that's why we got a split commission. So they could still have added one more commission. I mean, what's
True.
and especially looking at the value that it adds. But then the members of parliament, when they met in Naivasha, they committed to having a commission that addresses the issue of health management in the country. So,
and I think at the time, health was not at the center of politics like it is now. I think back then, the health workforce were not as vocal, because it's all of this. One of the proverbs City should add is, or Charles 2.5, you should add is,
Well done.
kila mwamba ngoma huvuta kwake. Everyone, you lobby and fight for what is of your interest. So at the time, the healthcare workforce were not as vocal and as active as they are now, or as you've seen since 2010, 2011. And that's why we've seen a lot of progress and tremendous progress in the health sector, not just about the kind of services, the kind of healthcare workforce, but also just having it as an everyday conversation that people will sit down and say, hey, let me hear what is being discussed here. What is the conversation about health? So I think this is probably the time for it then. And especially with the incoming administration that is looking at a bottom-up approach, then probably it's time to relook or have that conversation. The reason I say bottom-up is I was going through the Kenya Kwanza Manifesto on health, and they've really put emphasis on primary healthcare. And in Schedule 4, and that's what Umtata was saying just before he left, public health, for example, is one of the issues that was clearly devolved according to Schedule 4. And Kenya Kwanza is heavy. That's like their bottom pillar of healthcare in, addressing preventive, promotive services as opposed to pegging a lot on curative healthcare services. So yes, we may have a chance to have this conversation and actually to advance it and make sure something tangible comes out of it.
What is clear, as you say, when it comes to the health manifesto, it's like Kenya Kwanza consulted health practitioners and took the advice. Because I'm sure everyone who had a manifesto, and a health manifesto at that, had something to say. But if you look at some of the other manifestos, there are gaps. You look and it's like they're all over the place and you wonder, okay, so where exactly do you want us to go with this? Now, if someone doesn't focus on what you call basic health, yes, fundamental health services in a country such as ours, I think you've actually missed the point.
Oh, definitely.
And if you don't focus on the preventative aspects of healthcare, then now you really have an even bigger problem. Because even countries that we consider to be developed and countries that we consider to be wealthy, even they cannot afford the sort of health services that some of our people keep talking about. No, they can't. They will try, but they actually can't. And the reason is because the preventative aspect of the healthcare was long taken care of. So even when people seek health services, it isn't in the large numbers that we have, and it isn't with primary concerns being the main issue. No.
And looking at studies and future, is it predictions or projections of the healthcare? Projections, yeah. Of the healthcare concerns that will be in the country, we will have more non-communicable diseases affecting us than communicable diseases, the infections, the malarias, the pneumonias, There'll be a shift towards NCDs. But now if you look at it, if you put a lot of emphasis on prevention, on promoting health and well-being, you will avoid or you will reduce the chances of getting NCDs, cancers, diabetes, hypertension, which are costly to the healthcare system.
Extremely.
Because treatment in itself is expensive. Managing that is expensive. You need a highly specialized workforce, because if you think about it, if you need to do kidney transplant, it's not every Tom, Dick and Harry that will do. It's not any doctor that will do that. So there'll be a shift, and that becomes even more expensive. So if you have a chance now to save your population from that catastrophic health expenditure that is projected if they get non-communicable diseases, then this would be the time to act. And this would be the time to actually peg and put a lot of emphasis on making sure that your bottom tier of the pyramid is actually well taken care of, so that you have more public health officers, you have more environmental health officers at work, you have more community healthcare workers, no longer volunteers, paid for and doing their work, so that now we actually put boots on the ground to do the hard work of making sure that this population is healthy, so that you reduce the strain that comes on your secondary and tertiary level care.
This is what the Kenya Kwanza Manifesto says on healthcare. So they have three pillars: the fully publicly financed primary healthcare. Publicly financed is important to note. Second is universal seamless health insurance system, comprising a mandatory NHIF and a private insurance as complementary covers, with NHIF as the primary and private as secondary cover. And then they talk about a national fund for chronic and catastrophic illnesses and injury costs not covered or with very restrictive cover by insurance. These include cancer, diabetes, strokes and accident rehabilitation, pandemics. These are to be funded by a combination of insurance, levy and government. Those are big things.
They are.
But
It's So how I saw it, and I remember having a Twitter conversation with David D on the same, is you're basically reorganizing your finances so that you, like I think the primary healthcare, the publicly funded will take half the finances or the projection. So from the 550 billion shillings, which is the health expenditure, then half of that should be on
Going
the
to primary.
primary, which is now, if you do it right, it means your need for the secondary and tertiary is reduced because you're able to manage a lot of the things at the primary level. Now, when you go to secondary and tertiary, for example, so what they were saying was, if you go to facility X, for example, and they find that you have a kidney issue or a cancer something, then they take care of you and then refer you to either the next level of care, but then they claim whatever they have spent on you from that catastrophic fund, for example.
All right.
So that you're not told, this one, we will do the A, B, C, and D, pay us first. So that they just take care of you, they refer you to where you need specialized care, then the facility or the healthcare provider claims from
the fund.
From the fund, so that now you as a user, and that's the one thing that I've always been campaigning for, as a user, I have prepaid.
Yeah.
So at the point of care, I shouldn't need
just
to
accessing the
remove
service.
any cent.
Right.
So that now this becomes an issue of organizing how people get claims, even for emergency funds, any of this, so that now that becomes a conversation between government and the healthcare providers. So that my job as a citizen or as a mandatory NHIF payer is to make sure that I'm up to date with my premiums.
Yeah.
How difficult would that be to do? Because who are we pulling on here? Because it makes sense. Because is that not the situation that we have today? That even with your NHIF contribution, you're walking into hospital, the likelihood of you being asked to, fork out some extra funds is quite high for whatever reason. So with what you're talking about, how difficult would that be to do in the current state of things?
In the current state of things, it is challenging. Let me not say difficult, challenging, because NHIF is the fund manager, is the one that accredits or, onboards health facilities,
Service providers.
is the one that pays the claims, is the one that does everything. So one of the things that is there, now I'm starting to sound like Kenya Kwanza.
You've studied it.
Health.
Yeah, let's talk about what they're saying. Yes.
So what they're saying is that to reorganize NHIF so that you have somebody who's a fund manager who gets the funds, then somebody else processes the claim, so that you remove that you remove that codependence.
So the collector of the fund and the manager of the fund is different from
Yes.
the one who dispenses, expends the fund.
Exactly. So that you remove your chances of fraud or conflict of interest and things like that. So, for example, facility X, if I offend somebody in NHI, for example, this is just a hypothetical situation, they'll strike me out, and for whatever reason, because they hold the arm and the knife. They are able to say you can provide healthcare services under NHIF. If something goes wrong, they kick you out. But if somebody else is accrediting, and we already have those, we have the KHPOA Kenya Health Professionals Oversight Authority. They've looked at all our healthcare facilities, they've classified them, they've done all of that, so that is differently done. Your healthcare professionals have their own councils that accredit and deals with all of that, so that you have that. Now you come on this other side, you have somebody that is collecting the funds, so that my work is just to make sure everyone is mandatory, is paying, and we have all of these funds. Then now when the hospital X is claiming, they have somebody else that they come and say, we've offered all these services, our bill is 10 bob, pay us. So that now all of this is done differently, according to their plan.
I have an
You
issue.
people, I think
So,
you had.
listen to this implementation and reforms. The Kenya Kwanza Manifesto says we recognize that even though enrollment to NHIF is now mandatory by law, there are practical challenges of enrolling self-employed Kenyans who are the majority. Indeed, NHIF is already grappling with the challenge of intermittent contributions and people enrolling when they are sick, or they're referred to economic as adverse selection.
Adverse selection,
Yeah. A number of initiatives will be deployed to make enrollment easier for self-employed Kenyans, including 1, leveraging on the proposed primary health fund as platforms for community-based group schemes. Put that fund 1. 2, leveraging on the Hustler Fund and farmer organization initiatives to set up occupational schemes for trades, for example, boda boda, market women circles, and such. 3, affordable, flexible premium financing schemes, for example, contributes financed quarterly in advance. Contributors repay the loans weekly or other interval aligned with their income streams. Those are different. I don't get any of them.
So that from how I understood it is on the pooling aspect.
Okay.
Collecting funds so
Okay.
that we are a boda boda circle.
Yeah.
We organize ourselves to make sure we are regularly contributing.
Okay.
The Hustler Fund, if we are beneficiaries, we make sure we are contributing. So how I understood it was that was the part of pooling
Encouraging
funds.
more people
Yes, to
be-
put in.
to afford to pay.
Exactly.
Okay.
You've seen there was also a conversation of making payments favorable, so that if I'm on a daily wage, how much per day do I
you
need to contribute so that I meet the 300 shillings? Because one of the other proposals they have is that payments will be between 300 and 3,000 per household, depending on ability to pay. So that currently, for example, if you're both employed and say you're paying 1,000 shillings for ease of calculations, you'll both be paying 2,000 shillings as a couple,
Yep.
and you get the same funds that a single person who's paying 1,000 shillings only is getting.
Yeah.
So one of the proposals is to convert that also to become a household,
As household contribution.
so
Not-
that
not individual
not
contribution.
individual, so that it makes it more affordable, and then reduce some of these premiums, and they worked it out. And plus all of that, they look at getting 200 billion a year from the funds which are pooled. So there's an aspect of where do we get the funds from?
Because right now, for those who are okay, so now it's no longer at the voluntary contributor. With the new law, everybody's a mandatory contributor. Okay, I get it. So the new law, everybody, doesn't matter who, how many people are in the household, as long as they're adults, they contribute, right? But now, if we go into employment and it's mandatory as well to deduct, are you saying that, someone can come and claim, oh, no, here's a marriage certificate, a member of this household is already contributing, so the rest of us should not?
No, but look, if it's NHIF, they ask you the names of your dependents.
Yes.
Assuming they're your dependents.
Yes.
Spouse,
Children.
children.
And proof.
Yes. And once it is there, they are beneficiaries.
Yes.
So my confusion is what's new about this other thing?
It's
Because
a contribution.
It's the contribution.
The amount.
Yeah, the amount. Because
yes, but then if it is mandatory, you will be contributing anyway, and the eventuality will be the same.
So the issue now here is, you see, let's say you and your spouse are both contributing, and you have also already listed each other as beneficiaries. If you go to claim, you will get the same level of benefit as a single person.
Yes.
And yet, this household already has two contributors.
it's paying
Yes.
more.
Is paying double.
No, but that is good for the scheme. You see,
So from the mathematics, the economists worked out,
the health economists.
the health economists, yes, and I'm sure there are lots
the
of
costing
Then the
experts.
economists.
yeah, all of yes. So as an individual household, if you have been contributing the said 2,000, if now you're required to contribute 1,000 per household, it means you have 1,000 shillings per month available in your pocket. So for you as an individual, yes, as a household, it's a plus, because either way you have been contributing quote unquote double for the same benefits as an individual person. So they have looked at it, and we have 12 million households in the whole country. And so depending on ability to pay all of these things, 300 to 3,000 per month, which is 3,600 per year to
36,000.
Yeah, the math is
not mathing.
Is not mathing
Take it
today.
slowly.
Yes.
Take it slowly.
So it's a contribution per household for the 12 million households. And the math here was already you contribute our health expenditure, almost a third of it is out of pocket spending. Only 10% is from premiums. So since you are contributing out of pocket anyway, let's convert this to prepaid, which is now all of those hustler funds, mama mbogas, and everyone. You are contributing anyway out of pocket. So put all those money into these pooled funds. Say NHIF is the one pulling all of these funds, and you remove the out-of-pocket payment. And the math still comes to the same, which was about 200 billion if you combine out-of-pocket plus the insurance prepayments, both private and NHIF, so that it's not really asking you for more money than you're already doing, one. And two, as a household, they have saved you X amount that the other person was paying. So there's actually more money in your pocket as a household. So now the others, now I think now will be the details about how to make sure that if your spouse is the one being deducted in X company, you who is in Y company then can come and say, we already did on the other person's beneficiary list.
Okay.
So I think now, obviously, where the rubber will hit the road is how to make that
thing
translate into something that is workable and implementable.
This is the Situation Room, the only way to start your day.
We continue with the Healthy Friday conversation with Dr. Mercy KORIR, who joins us every Friday at 9 to 10 a.m. The Kenya Kwanza administration is already in office. They have taken leadership of the Houses of Parliament, both the National Assembly and the Senate. They will take leadership of the executive on Tuesday by 2 p.m. 2:01 p.m. It will be fully inaugurated, the Kenya Kwanza administration. There are things that they had promised to do when it comes to healthcare. We've just talked about, okay, how do you finance, especially the healthcare? How do you get the primary health working? The other thing that they also talked about is the supply of commodities. And they said, all right, so this whole issue of going to a hospital and then you're told, hatuna nini endo ulete gloves or go and buy painkillers from this particular. So that they want to address that. And this is what they say, that we'll establish a stakeholder-managed national procurement scheme along the lines of the Petroleum Products Procurement Scheme to leverage on bulk purchases and also to bring transparency and accountability in the public procurement process. KEMSA scandals must end. They go further to explain. Pharmaceuticals and consumable medical supplies account for an estimated 20% of total health expenditure, translating to domestic market worth of 110 billion shillings. Where? In 2020, pharmaceutical imports were 76 billion. That's 70% of the 110 billion estimate, meaning that when other imported supplies are factored in, domestic production supplies less than 20%. Domestic pharmaceutical manufacturers have the capacity to manufacture a bigger share competitively, but they are hampered by the high cost of doing business and the tax regime to extent of shifting manufacturing to neighboring EAC countries and exporting to Kenya. So this is what Kenya Kwanza is going to do from Tuesday. We will A, work with pharmaceutical industry to address the tax regime and the cost of doing business. We will B, leverage on UHC to identify and scale up manufacturing of essential supplies so we can do competitively. And C, leverage on our human capital to work towards a regional pharmaceutical manufacturing hub. So basically, they're saying local pharmaceutical manufacturers and manufacturers of other commodities will be supported, so that we get all the things, most of the things locally. Number two, when it comes to procurement, it'll be like an OTS for fuel, the open tender system. You, Mercy, you have a company that supplies, or you, Ndu, you have a company that supplies. Me, I am KEMSA. We all come to the table and we have been told these are the needs of the health sector in the next quarter, or the next half year, or the next year. We bid, and the lowest bidder is given the contract to supply.
So let me start with the manufacturing bit first. We have, I think now we are 42. Anyway, let's say about 30 to 40 local pharmaceutical manufacturers in Kenya with the capacity to do manufacturing and supply medicines.
Like
So-
manufacturing of medicine, dawa, dawa.
Dawa, yes, they do. For example, there's one here at Industrial that I was looking at their catalog. A dose of diabetes medicines for a month, full dose every day, was costing about 500 shillings.
Really?
Yes, because one, they are manufactured here, and two, because they are generic. So generics are tend to be cheaper because the R&D costs have been borne by somebody else. But the challenge has been the importation, and you've read it's 70% of the medicines that we have been imported. And when they're imported, there's duty, taxes, middlemen, all of these things that eventually make costs high. When I was talking to some of my colleagues in the private insurance, private medical insurance, 40% of the hospital bill, and if you look also at your bill, goes to medicine, because you have branded medicine, or you, for some reason, when you go to those top tier hospitals, medicines are a bit costly. So you get 40% of that is medicine. But if they were to take the medicines that are manufactured locally and you're given that price or that cost will reduce by half.
Yeah.
And that's what this manifesto is looking at. So there are two things here to look at. One is to have, do I call it a sensitization, public sensitization and awareness about generic versus branded medicines, because for a very long time, we've always assumed that generic are fake or counterfeit, which is not the case. Fake medicines, counterfeit are totally different. And when we're importing, we are at a higher risk of importing fakes and counterfeit because of wherever it is that they are being sourced. But if they are here manufactured locally,
Then
if
there's
I get
traceability.
if I get my medicine from Eric Pharmaceutical Company, if it has any problem, we know where you are.
Yep.
We know where and how to come for you and ask you what is the issue. And I've visited some of the manufacturing companies, and their quality standards and assurance is up to par with international standards. And so by all means, they should be able to manufacture. But now the issue has been on the taxes, on the cost. For example, if you even talk about electricity cost in itself, it really shoots up the overheads.
And that's why they're moving to other countries in the region.
Exactly, where manufacturing is different. So the Kenya Kwanza administration has to rethink and relook at how do we make manufacturing of these medicines less costly to the manufacturing companies so that they're able to supply these medicines. And so if you move that, so if you're spending 70% of your medicines on importation and you transfer that locally, that means that money that will circulate in the economy here. It means more employment, because now you're looking at need for more people in the factories, you're looking at the supply chain and everything that comes with that. So it has an attendant or a consequent benefit to the economy. Now, the open tender system, I think this was born from the many issues that we've had with KEMSA. Remember, even now, the employees were home.
Yep.
The other day, they were advertising to fill in so many slots. They have a new CEO. So KEMSA, for very many years, has been riddled with very many issues. And so I think this is just as a point of having open
So it's to introduce competition for KEMSA as well.
and transparency. Yes.
Improve your own efficiency, then you can compete competitively
Yes.
in the market. If
Yeah.
you don't, you'll be like National Oil.
Yes, and I hope through this they will give priority to local manufacturers so that we literally buy Kenya, build Kenya.
That's a very good thing on paper. You know, practically 70% blah, 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 blah means people's businesses. People's businesses means influence. Now, reality. Do you think this is actually implementable politically? On paper, the idea, fantastic. If you come to start implementing it, you're basically saying that Kenya Kwanza has got to look at the people who benefit from this and tell them, you guys,
They have to break the dam.
Yeah, as Okia
as
said,
Okia
go
was saying,
upstream.
go
and-
upstream and break the dam.
Yes.
They are the
drain
owners of the
zone.
dam.
So, personally, I think it's doable. The local manufacturers, there are certain medicines they cannot manufacture, say chemotherapy for cancer, some really high-end medicines which we cannot manufacture locally
Why can't we manufacture them?
because of the what's it called? The
Patent?
manufacturing. No.
Not patents.
No. The lines you have to because
The process.
The investments.
Yeah, the investment, that capital investment. Sometimes you weigh and you look at your market, then it's easier to import.
simply import.
So there's and if you look at say some cancer medicines, how many people will need? So it doesn't make economic sense to make that capital investment for something that may not give you a return unless you're assured of a wider market. So there are certain group of medicines that may not be able to be manufactured here. But now when you're looking at the essential medicines, paracetamol, amoxicillin, for example, this diabetes medication and hypertension medication, those can be manufactured here. So you can split actually and have your everyday high turnaround or high turnover medicines manufactured here. Then those who are importing then can focus
Specialize.
on this high end, which not everyone will need every day, and they are costly to even manufacture.
And that's where my problem comes in, Nancy. You see, when you're telling these barons that focus on only importing 20%, which is about 20 billion, as opposed to the 70 that you've been making, and then this 20 billion, also the consumption is not as high. When they were bringing the amoxicillin and the others, it's fast-moving
Yes.
medical supplies.
Also,
These
remember,
guys are going to push back hard.
Somebody has to buy the bullet
it is true.
for
but
for the better good of the country. Somebody has to.
Yeah.
Mercy, you are absolutely right. Absolutely. But reality, as Eric preambled this discussion at this level, is look at the association of business moguls and politicians and the involvement of politicians in business and how it is this just that matrix that I have actually spoken of is a lucrative one. So we are saying that given the involvement and even the contribution that these individuals have in the political processes that we have, you're saying you want to bring this to an end or you want to shake it up and you want to interfere with it. I've now introduced the reality, which is a political aspect of yes, how will this work?
Somebody has to.
If
buy
you
the
look
bullet.
at the KEMSA issue, okay, we are going to fry and quarter the people who work at KEMSA. But the political influence is what brought about that mess.
Yeah.
And which is still very alive today.
Yes.
It's still there.
And the players, if you look at the beneficiaries, we may not see them, but it's political. That is why, to date, the people who are actually involved have not been mentioned.
Yep.
So maybe then the question is, Mercy, that are those who are in a position to do something about it ready to then bring down the axe on these individuals who they know are holding the system ransom?
Political will.
Is the will there?
I hope they're ready.
I'm taking this discussion further. Are they willing to do it to themselves? Because
They're
some
the
of
ones.
these things don't work unless you have politicians who are at that high end involved. So, are they going to cut their own feet?
I hope they're willing.
The only way this, well, not the only way. one of the ways in which this could work is if the pressure then comes from the public. All right. So the authors of this very beautiful document are people who mean well, are people who just sit and they're looking at, okay, so this makes sense. Logic. This, logic. They have not interacting, and they are not interested in interacting with the politics at this particular stage. Now, if the rest of us can engage and say, this is what we'd like, this is what was promised, this is what we'd like, push. Even if you reduce that 70% importation to 65%, it's a step. And you're heading that direction. And then you're also telling President William Ruto and his health minister the point that we've got your back. And yes, you will not, because they're the same ones, you will not continue benefiting from this money that you've been making, you and your friends, but you will have the political support where you can then benefit elsewhere.
I think what gives me some hope, and I often say you cannot afford to not have any hope, is that this particular manifesto in general, but on the health aspect specifically, was developed after listening to the stakeholders, to the people who actually know where the shoe pinches, to the people who implement, the people who have to tell people, today medicine OS out of stock. So they had an input, they had a say in all of this. Even the manufacturing aspect, for example, was fronted by the Pharmaceutical Society of Kenya. So what gives me hope is that, one, it was a participatory conversation that involved those stakeholders at that level. But as you said, the next bit then should be to now come down and say to Mwananchi, this and this is what we have in mind. These are the details on how we think we can implement this, how we think we can put it together, so that you and I, as citizens and the potential beneficiaries of this, can understand and be part of that journey. So that, as you say, we have a pull effect on all of this conversation, as opposed to now having it as a creme de la creme kind of conversation and boardroom conversation to come down to
the
us.
elite to actually shoot themselves or cut
So
their feet.
I'm
like City is saying.
hoping that, because this was somebody said it's a statement of intent. I hope after the statement of intent and they've been given the mandate, the next bit is now to come and say, do Eric Charles 2.5, let's have this conversation. This is how we think we can continue with this particular health agenda.
What would you say would be the first steps towards this? Because even as we're saying, all right, so next Tuesday, then you're coming in. But it's a today problem. I mean, and the problems are today problems. What would you say would be the first thing that then ought to be tackled if they're taking, some of this advice?
So some of this, from what I see, is an issue of policy, for example. Say you can have a government policy where hospitals or distributors have 50% of their medicines locally sourced, for example. That one doesn't need a lot of, it doesn't need legislation. The other bits for NHIF, for example, have already been legislated through the NHIF Amendment Act. It's now mandatory to pay for NHIF. So it's now about having that blueprint, SOPs, whatever it is, to make sure that that is actualized and made to use. And what needs legislation, they have both houses of parliament. I think it shouldn't be difficult. So for me, what I see, and I think I was laughing when Okia was saying it doesn't want to be the one people are saying, I have not worked because this person has been going to court. I think they cannot say we are not able to do A, B, C, and D because we don't have the numbers. So for me, it's about, if this is what you said you'll do, you have the numbers. If you need to make any legislations, you need to do that. You'll have the government. So from a policy perspective, at the Ministry of Health, you can do that. From going down to county level, you have the numbers of the governors. You are able to, sell the idea, have a conversation, have their buy-in, and have that translate to, the county governments.
Yes, it is possible. But you see the question that Eric raised, perhaps a change of thinking. Are we saying that the political class who are in bed with the business class are willing to actually do the right thing, and instead of just profiteering, because this is what supplies do and importations, set up these industries. Look at this thing, make it a long-term project so that, yes, you will make money, perhaps even with bigger volumes, but you'll have invested. Because why do we have the term briefcase entrepreneurs in this country? There's an English word which was equivalent. It was manufactured in America after the Civil War. Okay, they were actually called carpetbaggers, meaning somebody who could actually carry all his belongings in a bag that could just go. Okay, now they were profiteers. They noticed after the Civil War the opportunities. They didn't build. They simply sought means, scary influence, do the other, and so when reconstruction was taking place, this is what happens with devolution. We are in essence reconstructing our economy. Now, do we have people who are willing to actually put in the back-breaking work of developing, building institutions, creating industry? Because when you import directly, you're not creating any industry, you're just making money. Okay. Now, that is the breaking of the dam that needs to take place. Now, does this party, does this political dispensation and the people who are going to run it, do they have the will to do it?
From the 14th day of September 2022, and 100 days after that, we'll be able to see.
We shall see. We shall see. They'll have no excuse at all.
No, they don't.
They'll have all the instruments of power. They'll have control of houses of parliament. They have a good number of governors who can start being, the implementers of some of these ideas in their counties. So everything, by the way, is aligned.
Is in place.
For Kenya Kwanza.
And goodwill from half
Yes.
the country that voted for the administration.
Yeah.
The way Kenyans work, they'll fall in line.
Goodwill is from everybody.
It's from everybody.
They'll
Okay.
if you listen to conversations,
Yep.
people have said it's okay.
Yeah.
Let's
Please,
go.
Yep.
you do what you
Now
need to
do
do.
it.
Then they have
Goodwill
the
is from
goodwill.
every Kenyan.